Every heartbeat starts as an electrical event, but not all cardiac cells make the same action potential. Ventricular myocytes and pacemaker cells behave differently, and understanding that difference explains half of clinical cardiology. Let's start with the ventricular action potential, the fast response. At rest, the ventricular cell sits at about minus 90 millivolts. This resting potential is maintained primarily by inward rectifier potassium channels that leak potassium out along its gradient. When an impulse arrives from a neighboring cell, the membrane depolarizes to threshold, around minus 70 millivolts, and 5 distinct phases unfold. Phase 0 is the rapid upstroke. Fast voltage-gated sodium channels open, sodium rushes in, and the membrane voltage shoots up to about plus 20 millivolts in 1 or 2 milliseconds. This is the fastest event in the cycle and determines how quickly the action potential propagates. Phase 1 is a brief early repolarization. Sodium channels inactivate, and a transient outward potassium current, ETO, creates a small downward notch. Phase 2 is the plateau, and this is unique to cardiac muscle. Calcium enters through L-type calcium channels, which balance out the potassium efflux. The membrane sits near 0 millivolts for roughly 200 milliseconds. This plateau is why cardiac muscle has such a long refractory period, and it's why the heart can't summate contractions like skeletal muscle. The plateau is also when calcium enters to trigger contraction. Phase 3 is repolarization. Calcium channels close, and delayed rectifier potassium channels, IKR and IKs, carry potassium out of the cell. The membrane returns to minus 90 millivolts. Phase 4 is the resting state, maintained by potassium leak channels and the sodium-potassium ATPase. Now the slow response, the pacemaker cells of the SA and AV nodes. These cells are fundamentally different. They have no true resting potential. Instead, they sit at about minus 60 millivolts and slowly drift upward on their own. This automatic drift is phase 4 of the nodal action potential, and it's driven by the funny current, IF, which flows through HCN channels. These channels are unusual because they open during hyperpolarization and let in sodium. As the cell drifts toward threshold, T-type calcium channels open briefly, then L-type calcium channels open, and this is phase 0 of the nodal action potential. Notice no sodium channels involved in the upstroke. The upstroke is calcium-driven, which is why it's slower. There's no true phase 1 or 2. Repolarization, phase 3, is driven by potassium efflux. This automatic drift in phase 4 is what we call automaticity. It's why the heart beats on its own without any nervous input. The SA node has the fastest intrinsic rate, about 60 to 100 beats per minute, which is why it's the dominant pacemaker. Latent pacemakers in the AV junction discharge at 40 to 60, and ventricular Purkinje cells at 20 to 40. These are your backups if the SA node fails. Refractory periods are critical to understanding arrhythmia. During the absolute refractory period, which spans most of the plateau, no stimulus, no matter how strong, can trigger another action potential because the sodium channels are inactivated. During the relative refractory period, at the tail end of phase 3, a stronger than normal stimulus can trigger a new beat, but it'll be abnormal. Clinical anchor. Long QT syndrome, whether congenital or drug-induced, prolongs phase 3 repolarization. When another beat fires during that prolonged vulnerable period, you can get triggered activity and torsades de pointes. Beta blockers slow the heart by blocking sympathetic effects on the funny current in the SA node, flattening the phase 4 slope. Class 1 antiarrhythmics. Sodium channel blockers. Slow phase 0 in ventricular myocytes. Class 3 drugs like amiodarone and sotalol prolong phase 3 by blocking potassium channels. Class 4, the non-dihydropyridine calcium channel blockers, verapamil and diltiazem, slow phased zero in nodal cells, which is why they slow AV conduction. Every antiarrhythmic drug maps onto a specific phase of a specific action potential. That's the electrical backbone of the heart. Fast response for contraction, slow response for timing.